Thank you, Chairman. Thank you for introduction. Dear colleagues, I'm very happy to share our experience about the management of aortic emergency in Macau. As we all know, Macau is a small city with a relatively small population. That means the absolute case volume of each specialty is not too large. And at the same time, Macau has a relatively independent and self-contained healthcare system. Most patients, they would like to choose a public hospital for the medical service. In the clinical practice, the low case volume but remarkable diversity of the disease has posed a significant challenge for specialties. So we must be capable of dealing with very complex, critical, and diverse cases. It is the same true for the aortic intervention, especially the emergent cases. Because the patient with aortic emergency, probably they will not have chance or condition to be transferred outside Macau. I would like to introduce some typical cases of our daily practice. First part is the management of the emergent aortic arch pathologies. This patient is a 63-year-old male presented with hemoptysis with hemorrhage shock, which was caused by complex arch aneurysm with ruptured PAU. And a simple TVAR was feasible, but for this ruptured aneurysm, we needed to take every effort to prevent possible endoleak. So we put a lot of coil inside the aneurysm sac and achieve a satisfied short-term outcome. For emergent arch vessels reconstruction, hybrid repair was commonly employed to date. And the specific technique is determined by the landing zone. This patient is a 75-year-old male, presented with a ruptured TAA and suffered cardiac arrest on table. And promptly we put a graft to exclude the rupture site, and then we do a bypass because this patient has a left dominant vertebral artery. This patient is a very young patient, 34-year-old male, suffered acute complicated Stanford B aortic dissection with severe visceral artery ischemia. And the landing zone is zone 1, and then we do a carotid to carotid to subclavian bypass to reconstruct the arch vessels, and this patient followed up in my OPD, and he's doing very well now. Another patient is a symptomatic aortic arch aneurysm. He's a 60-year-old male, presented with chest pain and hoarseness. A huge aortic arch aneurysm was found. And the landing zone is 0. At that time, we do a thoracotomy and perform the ascending aorta to bilateral carotid artery bypass and carotid artery to LSA bypass. This patient is an early patient. We have followed him 8 years, and he's also doing well now. The parallel technique or chimney technique is very useful for the emergent cases, even if it has risk of type 1 endoleak, because it's relatively easier to perform in some selective cases, like this patient, 80-year-old fragile male with a symptomatic arch aneurysm, and we performed the urgent TVAR with zero landing zone, and we constructed the BCT and LCC by chimney techniques. This patient also followed up for 6 years. The PMAG technique is widely used in mainland China and in some advanced regions, but in our center it's not commonly used. In the future, we hope we could enhance the training and increase the utilization of this technique. Off-the-shelf branch is another good option for treat aortic emergencies. But in our center, we only use it in some elective settings because we don't have the consignment. We hope in the future this problem could be solved. Then we can use this graft in the emergency cases. The second big part I would like to introduce is the management of the aortic emergency with visceral artery reconstruction. The commonly used method in our center so far is the parallel technique and off-the-shelf device. Like this patient we just managed recently, suffered acute aortic dissection with a ruptured AAA, a very complicated case. and a critical case. And we promptly performed the urgent TVAR with EVAR, cover all the whole aorta, and reconstruct the visceral arteries by chimney technique. We could notice that the patient has some endoleak, but I think it's acceptable. And I think just because of this endoleak, the patient did not present with spinal cord ischemia. Maybe sometimes it's a good thing. And this patient is also a case we just managed recently, a symptomatic large AAA with a very hostile neck. We could see from the image, the neck is very tortuous and the angle is over 90 degrees with very calcified and thrombus vessel wall. I think the standard EVAR off-the-shelf device and the PMAG is all not feasible for this case. So we use the new EXCC stent graft, just like Professor Yao introduced, to repair this case and extend the proximal landing. And the renal artery was constructed by chimney technique. And we could see the completion angiogram showed there's any endoleak. And off-the-shelf device is another good option for this kind of disease. Like this patient is 56-year-old male, presented with abdominal pain for 3 days. The angiogram showed the aortic pseudoaneurysm, very big. And we used the T-branch graft, which is the 4-branch off-the-shelf graft. And all the vessels were successfully reconstructed without any endoleak. And this patient also followed in my OPD 5 years, and he's also doing very well. The PMAG technique is not commonly used, but in some selective cases, we also treated using this technique. Because of the time limit, I will not introduce the details. In our daily practice, I think the most common aortic emergency is the ruptured AAA. Last year, we have treated 10 cases, and 9 survived, 1 died. All the method we use is the endovascular procedure. The result is not bad, but I think every patient and every procedure has its own story. And this case is the one who was dead. He presented with a ruptured aneurysm, but he has a very calcified iliac artery. We performed the standard EVA, and the immediate result is very good without any problem. But just after the patient moved from the operating table to the bed, patient suddenly cardiac arrest. And then we make an access again to do an angiogram. We could see the iliac artery has a very big hole ruptured. Even we do a endovascular repair, put a cover stent very fast. The patient, second day, passed away. And open repair is now seldomly used. This is a problem because the endovascular method we commonly use, we are familiar with that technique, but in some selective cases, it's very useful. We should do more work about this. I think for the ruptured aneurysm AAA management, our experience, technique, or skills are very important. But more important is we have to make a guideline or protocol in our hospital to collaborate different departments to work together. So in summary, for aortic emergency intervention in Macao, currently our strategy may not be perfect, but it is optimal so far. In the future, we should enhance acute aortic care capabilities, like to learn more about the PMAG techniques and build a specified high-efficiency aortic team and foster collaboration with leading centers across mainland China, Hong Kong, and the Asia-Pacific region. Thank you.